I take pleasure in introducing formally Dr. Ranganathan Iyer. And I know Dr. Ranganathan Iyer from year 2009 when we first organized infection control conference from Mahatma Gandhi Medical College. From that time, I think we have troubled him quite enough 2 or 3 times, including the WHO sponsored conference, which we did in 2010. And sir has been always a very popular speaker. And more than that, he has always accepted our invitations and he has he has been very generous in sharing his experience and ideas with us. So that is what. And in short, sir is the consultant clinical microbiologist in the Rainbow Hospitals and Perinatal Care, Hyderabad. He did his MBBS from Rural Medical College in Loni near Pune, University of Pune. And then he went to AFMC for his post-graduation. And he is, I think, one of the unique medical microbiologists who is trained in FRC path from Royal College of Pathologists, UK. And he is also a member of National Academy of Medical Sciences. His CV reads very impressive. He was spent 3 years in AFMC Pune, then Seth GS Medical College for 2 years. Then he moved over to Breach Candy for as senior clinical microbiologist. He was there for 7 years. And then he is into the Global Hospital Group, Hyderabad, for the last 20 years. Sir has been instrumental in many of the changes which have been brought out about the awareness about hospital-acquired infections, awareness about creating strategies for combating this multi-drug resistance organisms. His scientific contributions are quite impressive. He's got more than 32 publications and 49, I think, conference papers. He has contributed a book on how to collect clinical specimens for microbiology and all, and apart from books and chapters in books. He is a faculty and invited guest lecturer in many of the medical microbiology forums, including the conferences held in JIPMER and other places. He himself has organized 11 CMA's workshops, and he has won the best paper in mycology termed neonatal bloodstream candidiasis. That was in the Indian Association of Medical Microbiologists in 2006. So more than that, he has been involved continuously in that continuing professional development scheme of the Royal College of Pathologists of UK since the year 2018. And he is the country level leader and coordinator for the program of international training, that is from 2015. He is also an empaneled assessor for NABH and NABL and has contributed significantly. And more than that, his ideas on infection control and also in antimicrobial resistance, what needs to be done. He's a very vocal speaker and he keeps telling in all the forums what needs to be done and how it needs to be done. And the work in his parent institution in the Global Hospital stands testimony to all his efforts. Ladies and gentlemen, I present to you Dr. Ranganathan Iyer. Over to you, sir.
Thank you so much for that rather generous introduction to this audience. And yes, it's really been a pleasure knowing and being a part of various meetings, both in-house as well as zonal conferences and the WHO-sponsored conference that happened when Dr. Mahalakshmi was at the MGM, the Mahatma Gandhi Mission Hospital in Puducherry. And yes, I think the first time we came across each other was in the year 2009. And I think after that, there's been a regular interaction almost at least once in 2 years for some kind of a meeting on infections and infection control with Dr. Mahalakshmi as the lead person in organizing a particular meet at the MGM hospital. It's very nice. It's been a very, very nice and a pleasant experience knowing her, and as a very good professional colleague, as an academic professional colleague, and it gives me great pleasure participating in this particular webinar. Well, in this time of the COVID pandemic, obviously almost every single meeting has to be online for the good of everybody, so that more and more of us don't go down with the infection And this is one of the series where we could talk, we could still participate, we could still share our experiences, and yet be very safe at the places of work, away from infecting each other. And probably that's how the immediate future in 2021 is also going to be. I'll start with my first slide of the presentation. Can I have the presentation on? All right. Okay. Well, friends.
So if you say next, I'll move over.
Yeah, fine. So friends, this is a short overview on what have been the recent trends and challenges in the sphere of infection control, starting from around 2019, largely centered around what's actually happened in the year 2020 as far as infection control is concerned. Now, it's actually a huge sphere of work that needs to be all encompassed and presented in about 35 to 40 minutes. And needless to say, infection control and prevention is everyone's responsibility. That's the first thing. And that is generally ill understood. It is usually it is considered the responsibility of one person who is designated as the chairperson of the infection control committee. It is considered as the sole responsibility of the infection control officer. And that person is held responsible for what is done, what is overdone, what is not done, what is underdone. Unfortunately, not many people know that it is their responsibility as well. When they point one finger, three fingers point back to you. So that really needs to be understood when we talk about misendeavors and misadventures in infection control and prevention. It's a thankless job and it needs to be done very well. And fortunately, it's an absolute necessity in a healthcare institution. We can't get away without doing a proper infection control program in any hospital in modern medicine today. And of course, it helps to integrate almost all specialties. This is one particular subject, infection control and prevention, that brings together all specialties of medicine with prevention of infections and good patient care. Next slide, please. All right, these are some of the areas of concern for infection control next. And I'll begin the first area of carbapenem resistant gram negatives. Now, this is something that haunts all hospitals that I know of the world over. I mean, gone are the days when the Western Europe and the Americas could say that they don't deal with any multi-drug resistance. They also have as much multi-drug resistant bugs, whether they call it imported or exported ones, but then still they also grapple with the same kind of infections as we do. But then why are we interested in detection of CPE, carbapenem resistant enterobacteriales or Enterobacteriaceae? This includes primarily carbapenem resistant Klebsiella pneumoniae, carbapenem resistant E. coli, and some of the other members of the Enterobacteriaceae such as Enterobacter, Citrobacter, Hafnia, Serratia, and so on. That is precisely because the choice of what antibiotics you could use to treat patients with invasive infections is very limited. There is a very narrow preserved susceptibility to colistin, which has also come into question now, with colistin resistance coming up in a very big way in gram negatives. These patients, unless they are properly treated and adequately managed in intensive care units, carry a very high mortality and morbidity rate. Unfortunately, there is a horizontal transfer of these genes that help to elaborate the enzymes called carbapenemases, which is again mediated by mobile genetic elements. So what happens is one E. coli can transfer these genes to another E. coli. It can also transfer it to a Klebsiella from an E. coli. You can have carbapenemase genes transferred from an E. coli to an Enterobacter, sometimes even to some unrelated organisms and so on. So this is what is called as a horizontal transfer. This is a huge problem in infection control. That's because you try and treat one type of carbapenem resistant, say a bloodstream infection today, and you send the patient home. And again, after a month or so, if the patient is a diabetic and suffers another urosepsis episode, they could just come back with another bloodstream infection caused by an unrelated organism which is carbapenem resistant. In addition to this, there are resistance elements that confer resistance to groups of antibiotics. It is not just one single beta-lactam or one single quinolone that a particular organism would prove resistant to. They become resistant to quinolones, to aminoglycosides, to beta-lactams, to maybe the beta-lactam lactamase inhibitors, and so on. So it's something like groups of antibiotics which prove ineffective to treat these multi-drug resistant infections. They can easily spread through the hands of healthcare workers, through the hands of not just the healthcare workers. Now, this is another misnomer. You get these organisms only when you go to a hospital. No, it is not. You can get them in the community. You can get them in the hospital. So it's basically hand carriage, contaminated food, contaminated water. Because where are we trying and draining out all our sewage into the rivers, into the ponds, into the lakes? And those lakes supply drinking water to us. So mind you, whatever you discharge today is going to come back to you tomorrow in the form of contaminated water. And that is what helps colonizing the entire gut, that the whole of our gastrointestinal tract gets colonized with these organisms and the normal flora get poorly replaced. Community-acquired colonization, therefore, has been documented. And in the Rainbow Children's Hospital, in one particular year, we had about 1,478. That is, this was just about 3 months data. And what we do is we go and stick a meropenem disc on all our stool cultures, whether it comes from the community or whether it comes from the hospital ones. And we found 74 out of 1,478, which comes to approximately 5% of our stool cultures showing carbapenem resistant E. coli or Klebsiella. It may not be a pathogen, but then it still proves that the gut of that particular child is already colonized with a carbapenem resistant organism. And out of these 61 patients, just look at this, 61 patients out of 74 were outpatients. They were not even admitted to the hospital. They just come brought in by their mothers or fathers or both for an unrelated problem, say a diarrhea or a urinary tract infection, and secondary to a gastroenteritis and so on. And that gastroenteritis led the clinician to do a stool culture. And when we did a stool culture, we found it to be carbapenem resistant, Klebsiella or an E. coli colonized. So this colonization was found in almost 61 of 74 outpatients in a span of about 3 to 4 months. This is our data for approximately, it's about 4 to 5% colonization rate, which is really, really high. So just think about it. Your gut is already colonized in a small child with a carbapenem resistant organism. And if this child has to be operated tomorrow, say for an appendicectomy or for any other problem, if a procedure has to be done on this particular patient and they're put onto the table, you're already beginning to treat a carbapenem resistant organism. They don't have to get admitted to the hospital to pick up the bug. They are already coming in with the bug inside their gut. And this is the scale, this is the magnitude of the problem. The next slide, please. Right. So therefore, we come to this understanding that MDR GNB is not just in the hospitals, it's there in the community as well. It's more common, at least it appears to be more common in our part of the world, or at least that's what Western Europe and the Americas lead us to believe, that you people are the problems, you people are the sources of these infectious organisms. Wastewater systems and effluents from hospitals generally contribute to this. In addition to this, we also have sewage from various treatment plants and from homes and all that emptied into our river water, into our lake water and so on. Along with that, we also try and fortify to get huge and bigger size produced in agriculture with antibiotics. And the same antibiotics are also fed to sheep, to chicken, to poultry, and to pigs, and so on, so that you get better meat, you get more. You fatten up all these animals with antibiotics, and then you take the meat under the mistaken understanding that we are going to get better quality meat. But then, unfortunately, what we are actually consuming is antibiotic along with the meat, and that helps to bring in more antibiotic resistant organisms into the gut. So all this actually leads to a huge reservoir of gram negatives, particularly the enterobacteriales, with almost 10 to 12% of our fecal microbiology cultures showing a colonization. This is on an average, I'm telling you, when we look at our fecal microbiology cultures, particularly the pediatric age group, over a period of 1 year. Next slide, please. All right, now this is just to show you, now this is a slightly busy slide, but then if you concentrate, there are 3 types of gram negatives that we have. There are Enterobacteriaceae, which is your E. coli, Klebsiella, the Enterobacter, the Citrobacter, and so on here. Then you have a Cyanidobacter baumannii, which is a huge, hardy, multi-drug resistant pathogen which we have here. And then we have Pseudomonas aeruginosa, which is yet another non-fermenting gram negative, which comes mostly from moist areas. Now, if we look at the epidemiology of all these 3 organisms, hand carriage is usual. Quinolones and carbapenems administered to patients are a major risk factors with the Cyanidobacter. Hand carriage is a little lesser than moist contaminated areas in Pseudomonas. But definitely one needs to screen and isolate patients, at least in those areas which are non-endemic for multi-drug resistant gram negatives. Patient and staff education is something which is constantly required for all the 3 organisms. So there are certain features which are common to all the 3, and there are some differentiating features when we talk about, are we dealing with multi-drug resistant Enterobacterial? Are we dealing with a multi-drug resistant Cyanidobacter, or are we dealing with a multi-drug resistant Pseudomonas aeruginosa? Next slide, please. Next. Yeah, so these are some of the interventions for infection control that one could talk about. Hand hygiene, surveillance, environmental cleaning, decolonization of carriers, isolation and segregation. What do we do with our respiratory equipment? Are we going to have sensor taps, and are we going to put tap filters and so on? Or are we going to resort to a fecal microbiota transplant and put an exactly totally different normal flora, which we actually started off with when we were babies and then grew up to be infants and kids, and then now we are adults, and unfortunately all the flora is gone, and now we are all colonized with multi-drug resistant Klebsiellas. But then remember, one very important thing to remember in this is a single thing in any of these. If we take any one single measure and try and measure the efficacy of each of these alone, when done alone, the efficacy does not stand out as very good, except for maybe hand hygiene. That is the only infection control measure or intervention which could prove very, very efficacious in controlling a multi-drug resistant gram negative colonization or an infection. Otherwise, if you look at environmental cleaning and control, if you just because you wash the environment, clean after every patient and thrice a day alone, and don't bother about hand hygiene, don't bother about doing about isolation and segregation of infected or colonized patients, don't bother about your cleaning of respiratory equipment and so on, is your infection control problem going to come down? No, it will not come down. The same thing holds good for the others, such as surveillance, such as isolation and segregation. Sometimes isolation and segregation may not be practical in our situation, where India is supposed to be endemic for multi-drug resistant gram negative colonizers and infectious pathogens. It may not be possible. So if you have 90% of your patients, your inpatients in the hospital, all of them colonized with a multi-drug resistant gram negative, how are you going to go about isolating? Will you isolate all of them? Is it practically possible to isolate 90% of our patients? No, it is not possible. So in such a case, segregating and isolating only those high-risk groups. Say, for instance, if you have a patient like a transplant recipient, and that person is infected with an MDR gram-negative, probably you could isolate. Or if you have two patients, one is a transplant recipient and the other is not, and the one which is not a transplant recipient is infected, say, with a carbapenem-resistant Klebsiella, probably it makes sense to isolate that person away from the transplant recipient because you have an immunocompromised patient sitting next to the person who is infected or colonized with this MDR GNB. But otherwise, all these interventions for infection control must be done together along with a proper education program in infection control if one wishes to achieve anything in controlling multi-drug resistant gram-negative infections. Next slide, please. Right, after this I'll move on to, so multi-drug resistant gram-negative is one of the challenges that 2020 has been dealing with in the arena of infection control. Now to move on, we talk about operating rooms. Now there has been a lot of talk on infection control and the role of infection control practitioners in trying to advise which kind of surgical procedures should be done in which type of operating rooms. So if you look at the types of operating rooms, basically, we have a conventionally ventilated operating suite. This is something where you could do your laparoscopic cholecystectomies, you could do your hernias and hydroceles, you could do your mesh repairs and so on. Then you have ultra-clean ventilated or UCV operating suites. Now these are supposed to have laminar flow, and those are the ones which are used for cardiothoracic surgery, particularly the orthopedic procedures such as total hip and total knee, and maybe some of the cold orthopedic surgeries, including tumors. Then you also have it being used for transplants and sometimes for ophthalmology. The unventilated and the treatment rooms are almost the same. They are almost akin to the side rooms that we can see in some of our old, time-honored government general hospitals. Say probably if you go to Madras Medical College and the Government General Hospital, you would see some side rooms over there where you would incise and drain an abscess, where you would try and look at dressing an infected wound. And this is what you see in all these places like the Grand Medical College and JJ Group of hospitals in Bombay and so on. Next slide, please. So what are the issues of recent interest that has appeared in various publications in 2019 and 2020 are, what are the airflow patterns in operating rooms? When do we use a concept called as forced air warming in operating theaters? What do we do about people moving in and out with whatever they think is a very good surgical attire? How do we control traffic of personnel in and out of operating rooms? And of course, what has also got to do with biofouling of surgical power tools during routine use. So if we try and look at a couple of these at least for the sake of brevity, it would really be of great interest to see how things have appeared in the recent past. Next slide, please. So there have been multiple publications on this particular issue. Say, for instance, if you look at construction and the role of infection prevention practitioners in advising on how and what all parameters do you need to check in an operating suite before you declare it fit. Now, one of the commonest things that happens is surgeons try and put in their inputs. The administrators do whatever harm they can do. I'm sorry if I'm trying to hit upon any administrator in the group at Aarupadai Veedu Medical College. I don't mean offense, but then what happens is an infection control person is never, ever, ever taken into account. We do not form a part of the committee which decides while the building is coming up, while the operating suites are being built. That is the time when we need to be involved. So in case ABMC is coming up with another hospital, please bear this in mind and do involve your infection control team to advise you on what all needs to be done for an operating suite. So there is a lot to be done actually. It's not just air distribution systems. And the worst thing is, after doing all these things the way people want to do it, they just call upon microbiology department and say, please come and take your swabs and tell us whether everything is okay or not. Obviously, we're going to grow aerobic spore bearers, we grow MRSAs, we grow everything, and then people clean and clean and clean. At some point or the other, operations have to begin. So therefore, we say, okay, fine, now go ahead and start your surgeries. But then it doesn't mean that everything is hunky-dory or everything is perfectly okay. Before we actually come to microbiological surveillance, theatre interiors for obvious defects have to be checked. The air distribution within and between rooms of the theatre need to be checked. What is your AHUs, air handling unit? How have you done it? Now, if you really take a walk across some of the smaller hospitals, even in Puducherry, you would find that the air handling unit of the so-called operation theatre is common with the air handling unit of the rest of the hospital. So if that is so, then the air gets circulated all through the hospital. So what you're going to get into the OT is contaminated air from the rest of the hospital, as well as contaminated air from outside. So then at least you need to have filters. But then even those HEPA filters are not fit in properly. Setback ventilation and indications for the same. What are the air change rates in the theatre? It's extremely important to dwell on each of these points. I mean, if you take a look at all of these, it just gives you one idea. Engineering controls is so very important when you construct an operation theatre. And that engineer, the biomedical engineer and the hospital engineering department has to work in close liaison with the infection control officer. And that is when you get a reasonably good operation theatre done. And if you see, the last but not the least is airborne microbiological surveillance. It is not first on the list. Before we say, yes, this operation theatre is perfectly okay, you can start operating from day after tomorrow. Next slide, please. Next slide. Yeah. So now ultra clean ventilated theatre. Now what actually happens? How is it different from a conventionally ventilated theatre? So they found that there is a laminar flow of air. It's like a curtain that comes down from the top and it just moves like this, like a curtain. How you would put two curtains moving in opposite directions, it just moves that way. It's a unidirectional flow onto the surgical zone. So if you have an operation theatre table on at this level, and then the air just comes down like this and it moves away from the patient. So it's actually a zone of clean air, a column of clean air, sterile air that comes onto the operating field. Now this air gets recirculated in considerable volumes, and definitely we need filtration of this air because the air is actually drawn from outside. So it needs to be filtered with HEPA filters, and the efficiency of these HEPA filters, how do you know whether they're working or not? So therefore there has to be a check at least once in 6 months. Either you repair the HEPA filters or you change the HEPA filters, either of these two, but something needs to be done. The first thing is to install the HEPA filters. The second thing is to take care of them. Unfortunately, everybody talks about an ultra clean. We have laminar flow, we have everything, this thing, that thing. And when was it built? 12 years ago. And then how are you maintaining it? Oh yeah, at that time somebody had looked at it, but then we have never had a problem. How would you not have a problem if you don't change HEPA filters for 12 years? It's not possible. Next slide, please. So there is a lot of talk in the Journal of Hospital Infection, which came up saying that this is a paradoxical thing. They found that despite having laminar flow theatres, this is the time when they woke up to the fact that just because you have a laminar flow, just because you put some HEPA filters, doesn't mean that your surgical site wound infection rates will come down. They looked at the surgical site wound infection rates in orthopedic surgery, despite the best of facilities, and they found that the number of revision procedures, the number of revision arthroplasties of the hip and the knee increased, despite putting all the wonderful gadgets which everybody thought is going to save them from Yama, and still it did not save them from Yama. The revision procedures actually increased, and then they found out there are other factors, not just installing HEPA filters and trying to look at them, say maybe once in 2 years or 3 years. There is a total lack of theatre discipline, too many people coming in and out of the theatre and the ORs, no face masks over the nose and the mouth, or they're just over there for namesake, and very poor infection control practices, including hand washing and scrubbing by the team. All of this actually contributes to the surgical site wound infections, to the increased number of revision arthroplasties in orthopedic procedures, despite having all these wonderful gadgets fitted into to what is called as an ultra-clean ventilated theatre. Next slide, please. This came up in the Journal of Hospital Infections sometime in 2019. Now, a common thing, now we come down to microbiological surveillance. This is actually the last on the list, but then this is what we are normally called for. Come and take your swabs. Now, where do we take the swabs? This is a very common question which every infection control nurse who is appointed in the hospital comes up. Sir, they are asking us to take infection swabs from OT. Now, where do we take it? And if you leave it to the OT personnel to take it and send it to you, there'll be floor swabs, there'll be ceiling swabs, there'll be wall swabs, there'll be all sorts of swabs from everywhere, except the areas where they ought to have taken the swabs. These are the areas that come into close contact with the patient's skin and the mucosal surfaces. So therefore, the overhead lights, the head and the foot end of the table, the Boyle's apparatus for delivery of anesthesia gases, the interior of it, I mean, the suction apparatus, the inside of the tubing. You also need, what we actually need is from these, the laryngoscope blade and the handle separately, the face mask which delivers the gases on and the oxygen on and moistures it. These are the places where actually you need to take swabs. Instead of that, swabs are taken from the floor, the walls, and the ceiling of the OR. So we do grow staff, we do grow aerobic spore bearers, but then we just sort of disregard it and give out an NG report. So microbiology department then says, the general opinion is, anyway, whatever we collect and send to you, you're an NG department, you're a no-growth department. So we get nicknamed as a no-growth department. Actually, we are not a no-growth department because we don't grow anything out of our pockets. We grow what? We grow organisms from what material is supplied to us. So that's the problem. The problem is not about growing organisms. The problem is actually where are you taking your specimens from? That's very important. Next slide, please. Right. Now, coming to the next thing in operation theatres itself, forced air warming. Now, this particularly happens when you touch the colon. And this came to light when we started doing a lot of colonic surgeries when Dr. Orgainsed started operating in global. Hypothermia is one of the complications. It's one of the problems that is associated with both orthopedic surgeries, with colonic gastrointestinal surgeries, and sometimes with many other kind of procedures as well, even transplants to some extent. There is a cooling of the body, so therefore there is a loss of body heat, which actually increases the duration of the surgery. There is a risk of wound infection and pressure ulcers. There is an increased requirement for transfusion or even ventilation that increases the length of the stay in the ICU and therefore in the hospital. It also increases the risk of dysarrhythmias and sometimes MI. And there is a relative hypoxia of tissues with vasoconstriction. So to prevent this hypothermia, we have something called as air warming units, which the aim of this is to prevent hypothermia and all the adverse effects. This actually came up to a lot of lights. A lot of studies came up in the year 2019 and 2020, and I'll just try and show you what actually has come up in the last couple of years. Next slide, please. Now, this is an air warming method. This is a unit for air warming, which is FAW, forced air warming. There are two other systems which I'm not going to even talk about because there's a lot of physics and engineering construction which revolves around these units. This is a simple forced air warming, and this is how it gets delivered finally to the patient. Next. This is straight out of one of the review articles, but there are some infection concerns with the forced air warming. It's very important because what happens is you always keep the forced air warmer at the foot end of the patient. So it gives you one blast of air like this, and then there is a laminar flow of air that comes from the top. These two meet together, so and that creates an eddy current which actually disrupts the airflow in the theatre. This is one thing. The excess heat from these devices also can contribute to eddy current formation, and that can increase contamination at the surgical site. So this is one of the common problems that we have with a forced air warming. It's very important not to create this eddy current. So the place where you keep this particular air warmer is of paramount importance. And there have been a number of studies that have looked at this at different locations and how much of the air impinges onto the patient, trying to reduce the hypothermia versus the ultra clean ventilated air that keeps circulating as a laminar flow in the operation theatre. Next slide, please. I move on to, after operation theatres, I move on to the whole and soul, the most important, antimicrobial stewardship. Everyone is so very fond of. It's almost as if infection control is synonymous with antibiotic stewardship. And there are so many concepts which have been brought into antimicrobial stewardship. Unfortunately, what happens is people try and make it complex and complex and more complex and more complex. Actually, infection control, like one Professor Shine method from South Africa said, it's one of the easiest things. Infection control is one of the simple, plain, logical, easy things in a hospital to do. But then I don't know why we try and complicate this just because we would like to draw more attention to ourselves as infection control practitioners. Antibiotic stewardship is a classic example which I can give, where people have added to its complexity by leaps and bounds. But then if you look at this definition, which is straight out of a textbook again, it's from Glenn and Mayhall. A set of measures or interventions delivered by a multidisciplinary team working in healthcare institutions, the aim being to optimize antimicrobial use among patients, the aim again being to improve patient outcomes, ensure a cost-effective therapy, reduce adverse sequelae of antimicrobial use, such as antimicrobial resistance and Clostridium difficile infection. Now, if you look at this, each and every word is very important. It's a set of measures or interventions, which means it's not one single thing that you do today and it's going to hold good for the rest of your life. It doesn't happen that way. It's a multidisciplinary team. So again, just like infection control, it's everybody's responsibility. It is not just pinpointed to one particular person, and if something goes wrong, that person is to be checked out. No. Where do you do this? In a healthcare institution. Why is it done? To optimize antimicrobial use. The word optimize is very important. I don't mean restrict. Now, one of the commonest problems with, which clinicians face is, oh, the AMS guys, the antimicrobial stewardship guys want to come and restrict. The common mistaken notion is you are trying to curtail my antibiotic prescriptions. The aim is not to curtail anybody. The aim is not to restrict anything. It is to optimize the use of antimicrobial so that it is used for the correct indications at the correct time, for the correct duration, at the correct dose, which improves patient outcomes and definitely ensures cost-effective therapy. Next slide, please. Right. So these are some of the goals of the program: to increase the frequency of appropriate antibiotic prescribing practice, which goes on to treatment of infections, minimizing your adverse events, and definitely reducing the amount of antimicrobial resistance and the incidence of Clostridium difficile antibiotic associated diarrhea, which we see very commonly in our hospitals. Yes, so this is know when antibiotics work and try and get smart in healthcare with regards to this. Next slide, please. Yeah, these are the core elements of any antimicrobial stewardship program. There has to be a management committee, a commitment. So, sirs and madam, all of you are sitting right at the top, the dean, the chairman, the principal, the director, everybody has to have a commitment. Otherwise, it will never, this is something which doesn't start at the bottom and go up, it percolates down. So it starts from the top and comes down. So it's very, very important for the management to have a commitment. Administration comes into play a lot for a good AMS program. That helps to formulate guidelines, implementation, Well, I mean, without guidelines, you don't implement anything. Unless you implement, you don't monitor. And the whole thing has to be quality assured. So these are the core elements of any antibiotic stewardship program. Next slide, please. Right. Now, this is something that appeared in the Journal of Hospital Infection 2020. We had a COVID-19 pandemic, which is still going on. It's an ongoing pandemic, but has antimicrobial resistance work, AMR work, has it suffered? The WHO came up in 2011 and said that there is an emergency. AMR is an emergency. That's how it was declared, with that arrow which went through a target. I'm sure everyone has seen that poster from the WHO. But then probably AMR has suffered because of COVID-19. The reasons being there has been a disruption because of clinical service delivery during the pandemic. A lot of people stayed at home. A lot of people came only for a few hours. There was a lot of screening of people. A lot of people were not given care. A lot of people were given selective care. There was a bit of a slant towards caring for the COVID-19 patients and the complications thereof. There has also been a disruption in global antibiotic supply chains. That's because a lot of companies went into lockdown, countries went into lockdown. There was a lack of transportation facilities. So therefore, antibiotics could not reach where they should have reached at the correct time. There was also a tendency to overtreat hospitalized COVID-19 patients with antibiotics. This was a viral infection, and still we saw hordes and hordes of dihydroxychloroquine, tetracyclines, azithromycin, ivermectin, all of that being put into use to treat COVID-19. So you're trying to use antifungals, antiparasitic antibiotics, along with antivirals to treat a viral infection. So obviously, the remaining bugs like Streptococcus pneumoniae and Haemophilus influenzae and some of your other organisms are going to pick up resistance to these antibiotics. So what were the interventions that would be necessary, at least now? Restrict the number of antibiotics that you would use to treat COVID-19 patients, unless there is a secondary bacterial infection, unless there is an infective complication. Offset the costs of AMS with reduced hospital stay and readmission rates. Support your diagnostic stewardship program. Most of the times, we try and give in a cocktail of medicines because we don't know what we're dealing with in a particular case. So diagnostic facilities must be supported, which means your pathology, biochemistry, and microbiology departments must really work. They must work. The laboratories must function 24/7. People must be available. But for them to work, there has to be material and supplies available. Stop carbapenem prophylaxis for certain procedures. And finally, be very judicious in your decolonization regimens as an AMS measure. Next slide, please. So these are some of the broad interventions. Try and formally reassess the need and the choice of antibiotics so that you have a timeout for antibiotics. Do not interfere at the same time with the treatment of sepsis and septic shock. There you need antibiotics, give it. But then it's very important to have that very fine line, a neat balance between the two of what we ought to do and what we shouldn't desist from doing. Next slide, please. Right. These are also some of the things which are very important. When do we shift from IV to oral? When do we dose adjust and optimize antibiotics? Do we have automatic alerts with duplications, stop orders? Are we looking at drug-drug interactions when we are giving a cocktail of medicines to one particular patient? And of course, also review clinical information for antibiotic timeouts. Next. Right. Now, this is something that one could adopt as a measure for good AMS practices. Try and have an infection and syndrome specific intervention. Very important to diagnostically evaluate and come to a consensus of one particular diagnosis before and then optimize your empiric treatment in the meantime, reevaluate the need and the choice and prescribe the correct antibiotic for defined infections such as some of these. So it's very important to timely modify based on culture and antibiotic sensitivity results. That is something which would go a long way as a guidance for appropriate use of antibiotics. Next slide, please. These are just to show you that quality indicators also do exist in an AMS program. Next, I'm just going to skip this and move fast. Okay, next. Who is to play what role in AMS? This is something which is very important. The issue normally comes to a halt at the doctor's doorstep. Everybody feels that only doctors have a role to play in antimicrobial stewardship. The role of the other members of the team is largely undefined. And in recent times, next slide, please. In recent times, in 2020, there were two very, very good articles that brought out the role of nursing staff in antimicrobial stewardship. And this was one Singapore study which concentrated on qualitative analysis, understanding what barriers can exist if nurses have to be empowered in an antimicrobial stewardship program, and how could their involvement be increased, with a lot of focus group discussion. And then they found that if you leave nurses to themselves, they found that antibiotic administration by these nursing staff is perfectly okay. But where was the problem is, there was a lack of knowledge, a lack of expertise in antibiotic use. They didn't know how doctors would perceive if they tried intervening, or would they be seen as street smart or unnecessarily smart and even checked out for that? Is it okay for them to voice safety concerns, sometimes things which are overlooked by the medical staff? And can they suggest drug administration guidelines? Now, this came up in 2020 as one of the very good studies from Singapore. And there is a need, there is an increasing need, because just having medical staff looking at AMS may not be appropriate, may not be good enough. We also need to involve our nursing staff. Next slide, please. Similarly, we had yet another study from Australia, which almost spoke, and this has come up in January 2021. So I really thought that I would bring this to you. This was a systematic review, and it looked at knowledge, perceptions, and experience of nurses on antibiotic optimization, particularly restricted to the intensive care. Again, the role of a nurse. If the role of the nurse in the ward is not defined, the role of the nurse in the in the intensive care unit is definitely going to be lesser defined for AMS programs. And there were almost about 20 years of publications analyzed. And what they found is that there is a great potential among nurses in the ICU on antibiotic use, reducing the time to administration, and definitely they could reduce error rates. But these were the barriers to their role, but again focusing on knowledge deficits, interprofessional problems on how they would be seen by doctors, and the solutions proposed were enhance their education, technology utilization, give a very strong nursing leadership so that nobody's going to get cowed down just because a senior physician or a senior surgeon comes and says, this is what I will do. You, all of you, just listen to me. No, it wouldn't be that way, because everybody has a role to play in antimicrobial stewardship. Next slide, please. Right. I'll come on to hand hygiene. Now, this is something which we all love talking about. Hand hygiene is something that has come to the fore since the 1990s, and it is there even with us today. Next. So how have we fared with hand hygiene? Everybody, the general consensus of opinion is there have been beautiful pearls with hand hygiene, because the COVID pandemic, one of the prevention measures was wash your hands, wash your hands, wash your hands, and wash your hands. All right. So hand hygiene is improved in many instances in the pandemic. There is an increased compliance among healthcare workers, but unfortunately, these are some of the problems. Everybody who is working will follow hand hygiene, but there is a general shortage of nursing staff and doctors. There has been a layoff of staff in many healthcare institutions, and that has been related to bed occupancy. The occupancy is only less, so therefore, why do we need so many staff? So this has a lot of problems with a lack of ownership. And this has brought us, and this brings us to the next point. Next slide, please. Go on, next slide. Yeah. So this is a South African study. No, one slide before. This was a South African study. It was a quasi-experimental study in 5 phases. They took a general audit before they put in these 5 steps. Executive governance behavior changes, group-wide situational analysis, electronic data collected with direct observation and analysis. Then they launched and implemented very good hand hygiene compliance programs. And then they made people accountable right from the top to the bottom. And then they found that the baseline compliance was actually less than 60%, but over an eight-month period, post-implementation, the compliance jumped by 8 to 10%, which is very good, which is wonderful, which just clearly shows that if you have a multi-pronged approach, it does help in improving hand hygiene, starting at the managerial and the administrative level, and definitely that improves HH compliance. It's very important, again, for managerial administrative support for healthcare workers to have very good hand hygiene compliance. Next slide, please. Right, implementation. Now, what are the problems? I mean, when it comes to implementation, why is implementation of hand hygiene suffered? Probably there are time constraints. If it's an outsourced agency staff who are going to come and stand outside, or nurses are procured from another agency, it happens in many of our hospitals. Who's going to keep training? Because there is a huge attrition of nursing staff. There is a huge attrition of even doctors these days. There is a huge attrition of the class 3 and the class 4 employees. So therefore, you have a lot to do with management commitment. Continued staff motivation is another challenge. Who's going to keep motivating them? Who's going to put pressure on observers? The risk of potential punitive action. If you don't wash your hands, I'll throw you out after 3 times. Now, these are statements which can sometimes demoralize people rather than encourage them to have very good hand hygiene compliance. Hostility from fellow colleagues and other staff in hospitals. This is something which we face when we go around trying to ask people to wash hands. The general thing is he has no other work rather than to come and ask us to do hand hygiene all the time. Next slide, please. Next slide. Yeah. Visitors. This is something which was extremely important. Just one slide back, ma'am. Yeah, I just touch on this visitors. This was another study that came up from India, and it was published in the Journal of Hospital Infection, which is a UK journal, and this talked about challenge in educating and monitoring relatives and visitors. It's not enough just looking at our healthcare workers. You also look at visitors and relatives of patients who come to see their near and dear ones in the hospital, because they seem to have a significant contact with patients. And infection control nurses were put to work observing hand hygiene of visitors over 4 years. The percentage was calculated, and then they looked at the compliance. They found that the compliance was much better among visitors and relatives in medical than surgical wards, better in pediatric than in adult units. The mother of a newborn was much more amenable to some education on hand hygiene increase. It came to 77%. Look at this figure, 77% among the mothers of newborns versus 45% of the rest of the visitors. So probably everything started from 20%, but then here it jumped to 77%, whereas here it just came to a meager 45%. So which means the mother of a newborn, because they care for their baby, so they don't want their babies to get infected. So therefore they wash hands very judiciously, and this was one of the striking things which this study found. And this was published in Journal of Hospital Infection in 2020. Next slide.
Sir, may I remind you, we have about 10 minutes more to close.
Yeah. This is one of the last ones that I'm doing. Face masks. I really thought that I must touch on face masks, N95 masks. This is something which we have been using during our COVID-19 pandemic. And one of the common questions which I'm sure it has plagued even you all is, how do we reuse masks? First of all, there was a shortage of masks. Second thing is the N95s were very, very expensive. So therefore, there was a general consensus of opinion that these must be reused. But then the company and all the WHO guidelines and everybody tells you to throw off those masks after one use. After an 8-hour shift, take it out, throw along with the rest of your PPE. Now, how does one reprocess this in a very safe manner? Next slide, please. So there were some measures which looked at this. There were some 2 or 3 measures which are fairly good. One is, if you have a vaporized hydrogen peroxide, a STERAD, a STERAD low temperature sterilizer in the hospital, normally it's the concentration of vaporized hydrogen peroxide used is around 35%. But then if you use it at 59 to 60%, the filtration efficiency in the fit test when done, so it showed very good filtration efficiency, very good, and it passed the fit test even after 5 to 10 cycles of vaporized hydrogen peroxide as compared to the controls. So therefore, it's useful in an N95 shortage in the COVID pandemic. This came up in January 2021 as a study. Somewhere in 2020, Canada came up with a microwave heat-based treatment of N95 masks and respirators. They also found that the filtration efficiency and fit test, probably these are the two main markers that you study in an N95 mask. And they showed that the log10 reduction of organisms was very, very good. Therefore, increasing filtration efficiency, passing the fit test when you use microwaving and heat effect. However, autoclaving did affect the physical characteristics of the N95 mask, and that and any heat which is more than 90 degrees may not be suitable. This is something which we must remember. The next slide, please. There was a third method which I would like to touch on, the gravity stream reprocessing. This is a non-toxic gravity stream method. What actually happens here is you expose the masks at 121 degrees for about 30 minutes to steam under pressure. Autoclaving, followed by 30 minutes of heat drying. And then you check for physical traits and function tests. It passed the function tests after 3 cycles. But then if you increase the number of cycles, then it does not pass, and the physical characteristics also suffer. Probably this is also purported as a useful method for reprocessing our N95s when there is a shortage. Again, this came up in 2020. I think that's one of the last slides for this presentation. Yes. So I have tried to touch on some of the most important things, because the rest of infection control on VAP and CRBSI and everything is something which is understood by one and all. I don't need to sit over here and teach people on ventilator-associated pneumonia. That's not something which you're looking forward to. I've tried to put together some of the recent happenings, the recent trends in various areas of infection control, which probably has a direct impact on our work, on our routine work in hospital infection control, probably in the next few months to come. Thank you so much.
Thank you, Dr. Ranganathan, for that wonderful lecture. Actually, listening to you talk, right, it made me realize 2 things. One is, I wish you were our microbiology teacher. No, the way you pronounce the names of organisms itself is so very nice to hear, right? It makes it very interesting. The second thing is, I wish I was as smart as bacteria, or our students are as smart as bacteria. What all they don't do, they share information in groups, they actually reprocess information and then take similar characteristics across. So if such traits were built upon in our students, then there is no comparison, right? We'd go somewhere. So that is jokes apart. There is one question which Dr. Bhatt has asked. He's our medical director for research. So he wants to know, like, whether you advise periodic fumigation of OTs and ICUs.
No, we do not advise periodic fumigation. Fumigation is something which is completely out. Fumigation was out about 15 years ago. And then for the next 5 to 7 years, there was some talk about fogging, hydrogen peroxide fogging of theaters. Even that is completely out of vogue, though of course many of the theaters are still fogged with hydrogen peroxide. It doesn't harm anything, but then it doesn't help you. I mean, it just leaves you with a false sense of security that everything is well, all is well, as you know, the film 3 Idiots taught us, all is well, all is well. I mean, you keep beating your chest and saying all is well, but then finally it all amounts to cleaning at the end of the day. Scrubbing, cleaning of surfaces, cleaning of the OT table, cleaning of the surroundings, having a good wash down at the end of the day. That's what makes it ready for use the next day. No amount of fumigation or fogging is going to help. And anyway, formaldehyde is given up because it's supposed to be corrosive, it's supposed to be a co-carcinogen, and so on. So I wouldn't recommend fogging at all. I mean, fumigation at all.
Thank you, sir.
Hello. Sorry.
Okay. It's okay. Thank you, sir. The other question which came about, right? This all started with the Times exposure of Nixon scandal. No, people talked about academic or professional freedom, the boundaries versus the restrictions which have been put forth in the name of quality assurance or in the name of stewardship for many of these things. So, what is the kind of resistance you face when we actually talk about this antimicrobial stewardship program?
Yes, I have faced resistance, particularly when I was at the Breach Candy Hospital. That was a time, that was in the 1990s when the concept of antimicrobial stewardship was still at its infancy. It had not hit the Indian shores. It was still an American concept. We couldn't go, I mean, just imagine going up to somebody like Dr. Farooq Udwadia or big heavyweights as they are called. So say Dr. Tempton Udwadia, you're a surgeon, so you would definitely recognize the name Dr. Tempton Udwadia, or so say for instance Dr. A.S. Modalayar in Madras, and ask him and tell him not to use this particular antibiotic. Now, wouldn't they ask you to get out from that place? They would, obviously. So that, I mean, there is an immediate resistance that one follows. What I have come to realize is, try and sit with each department. Do not call for a full meeting. Try and form a committee. And then the person who jots down, who tries to formulate an antibiotic policy, goes around meeting individual departments, talk one-to-one, and put forth certain clinical situations and what kind of antibiotics is normally used and could they also use this instead of the previous one. Once they agree upon, try and type it out and get a signature from them, give them a copy, and then after that, you could monitor. It's no point but the common mistake which is made in the name of antimicrobial stewardship is just policing around. Now, policing around can put off anybody. Obviously, the more senior the doctor, the more put off they become. The faster, I mean, the easier it is to put them off, because nobody's going to take very kindly to restricting their antibiotic prescriptions. It has to be a gradual process. A lot of, what should I say, interpersonal, interprofessional relationships, friendships is something, understanding between people is something that goes a long way in cementing antimicrobial stewardship. That's something which helps. I mean, one needs to build relations, drop bridges, and then reach out to people. That is probably when it works. When there is an understanding, they also know that you're not trying to impinge onto their area. We're not trying to tell surgeons how to operate. We're just trying to tell them that in this situation, could you please just use this antibiotic and not that? That's it. Once that is done, I worked with surgeons over here in Global for almost 20 years. They're not a bad sort at all. They're just a breed apart, that's all. And it's
excellent breed apart.
Yeah. Yes, I never said that you are a horrible breed apart. I only said that you are a breed apart. That's it. It's been very nice working with surgeons. It's just that one shouldn't, I mean, it's not a good practice to just keep policing around people. And the worst thing is, when people are unmindful of what actually a patient's diagnosis is, and you go and stop antibiotics and to try to argue on stopping antibiotics or coming down on antibiotics when a patient is dying of sepsis and septic shock. I mean, how can you curtail antibiotics over there? You cannot curtail antibiotic use over there. For whatever it's worth, meropenem and colistin and vancomycin has to be used in that particular scenario. We dare not get into those kind of situations. It's very important to start with the community OPD treatment and then move on to the ICUs. People generally fear to start the other way around. They come down from the ICUs to the OPD, which is not right. That's what I feel.
Yeah. So you would say from bottoms up for antibiotic policy formation. That is good. We'll ask. Yes, sir. I'd like to ask our Dean if he has any questions, comments. Dr. Kotur? Hello?
Yeah, thank you, Professor Mahalakshmi. See, certainly as a head of the institution, I have got a couple of thoughts on this occasion. One is, this platform of FFF webinar. Dr. Iyer is the third microbiologist who has shared the platform. The first one to be, we all know, Dr. None other than Dr. Vishnu Mohan Katoj. He shared his ideas, followed by a professor from AIMS Bhopal. He had a wonderful session on about something related to infection, especially when the COVID was at its peak. And he narrated in such a wonderful way the many measures, many methods indigenously developed, how by practicing them, they could shield the spread of this infection during that time, which were quite convincing with the data he spoke. That is one thought, certainly. And I also must thank today's speaker, the resource person, for giving his thoughts to enrich the whole atmosphere over here. Now, I'm an anesthesiologist. Of course, I've been I was even heading the OTP committee, etc. And one thing is, as rightly pointed out by the speaker, including the hospital infection committee control, every hospital, is definitely no OT committee is without a microbiologist. That's one. And one more thought is the right appropriate in the sense our AVMC management has laid down the foundation stone for a wonderful state-of-art hospital, super specialty hospital in the campus. Only last week, only the foundation stone was laid, wherein we have dreamt to have a state-of-art with the super specialty departments, 130 critical care beds, etc. And certainly, the one more thing also, our resource person will be happy to know that we have got a very strong, dedicated team of microbiologists over here in our institution itself. And certainly, they will not be disappointing your thoughts, what you are thinking. And one more thing is, and I also am an ardent follower of evidence-based medicine. $1 million question haunts my mind. Are we right in applying the evidence generated in a developed country, in a developing country like India? That is really a question. Why I'm raising this issue is, as per the statement made by none other than the former ICMR Director General, Dr. Mrs. Soumya Swaminathan, who is the chief scientist at WHO now, she said that India doesn't have any statistics of the hospital-acquired infections at all. Bold statement given at the WHO platform. When such is the condition, we have to think 10 times when we apply, be it a guideline, be it a protocol, be it a SOP generated elsewhere, to apply to our patients and get a good outcome. That is one. The wisdom lies in us, in whether to apply to our group of patients, whether to apply to our environment, to our circumstances. I hope our resource person will concur with that. And also he will be happy to know that as a mandate of the regulating council, our accredited NABH lab also is functional, which done human service during the time of this COVID. So these are some of the thoughts that have come to my mind. I think, I expect our resource person to share to answer the possible question. Are we justified in applying the evidence generated in the developed world in a developing country or underdeveloped country like India? Yeah.
Yeah. Now, first of all, sir, India is a developing country. Yes. I mean, I don't think we could call it an underdeveloped country. That's
developing, yes.
Yeah, developing nation. Now, the second thing is, are we justified in bringing the rules of the West to India? Yes and no is my answer. Now, there are certain areas where we do not even have baseline data. Now, everybody talks about the need for a baseline data, but then unfortunately, it's never built up. It's never built up. It doesn't happen at all. There has to be a concerted effort. Probably, it's no point saying at the national level we would do this because it's too big a country, probably. So my thought process tells me that it's much better to do it region-wise and see what is your basic healthcare associated infection rates in various categories. What are the basic problems that we all face? And then look at Western guidelines. Now, any kind of guideline, it's a guideline. It doesn't mean, it's not a diktat that you have to do only that and not something else. A guideline taken from the West can be taken, but then it needs to be customized to our situation, the way our things function, the way our environment functions. Now, there was a talk about do not clean your OT. There's no need to clean your OT. This is something that came from the US once. You don't need to fog at all. But then how many of our hospitals don't fog at all? This is, I mean, we all still do believe in fogging the theaters. That is because our environment is completely different from what exists in the West. So guidelines from the West should be taken, should be read, can be taken, but then it's much better if we are able to customize it, modify it, not follow it verbatim, because it's not possible to follow many of those things verbatim over here. We would be making utter fools of ourselves. It's better to customize it to our situation and our circumstances, for which we need to have a good in-depth understanding of our own circumstances. So the bottom line is, first thing is look at our own problems, understand them, and then see how best you could borrow material from the West and try and customize it to arrive at solutions to our problems here.
Thank you, Dr. Ranganathan. Sir.
Yeah. Okay. Thank you, Dr. Ranganathan. Yeah.
Thanks. Thank you.
Go ahead.
Thanks so much.
Okay. So, I would like to thank Dr. Ranganathan for this talk, which was actually started as a very panoramic view. It started as what all has happened in infection control over the last 1 or 2 years. And then he moved down into magnified view of certain specific problems. And what I was really impressive about the entire talk, or at least to me, was that you talked about the marriage between the technology, logic, and clear thinking and common sense in infection control practices, and how we can actually translate many of these big words into practice, right? How we can put it into what do we call thumbtacks for real use. So that was what I think was the most impressive and take-home message from the entire thing. And we also really appreciate the way in which you brought in the terrible trio, no? Hypothermia, acidosis, bleeding, that complications in OT, and how infection control goes for a 6 when this happens, and hospital-acquired infections take a major role in the morbidity of the patients. So this is what is, I think, in summary, the take-home message for all of us. And thank you very much for a wonderful session, sir. It has always been a pleasure listening to you.
Same here. Thank you. Thank you so much.
Okay. Thank you, sir. So on behalf of this scientific forum of AVMCH and VMRH, we thank our speaker. And before I close, I would like to say a few things to our participants. One is this session is recorded and it went live in the YouTube also. So we would share the link. It is available in our YouTube channel. We'll also share the link with the participants so that you can go back and watch it anytime you want to get clarified on certain points. And the other thing is for the next week, we'll be continuing the same series on emerging and re-emerging infections. And we have another interesting topic next week. That is, we are going to talk about what is new in pediatric pulmonary tuberculosis. And we have none other than Dr. Sushil Kumar Kabra. He is actually a pediatrician and the head of neonatology, pediatric pulmonary division of AIIMS, New Delhi. So he is going to talk to us about what is new in pediatric pulmonary tuberculosis. And Dr. Kabra also happens to be the chief editor of Indian Journal of Pediatrics. So I think he will share his rich experiences on that particular topic. So with this, I'll close today's session. I thank everyone for the wonderful session and also for the interest shown by the participants. Thank you very much. Thank you, Dr. Ranganathan.
Thank you so much.
Bye-bye.
Thank you. Bye.